Dr. Cornelius, can I ask a quick question about the previous exam? Are we going to be able to see it at all and
We'll go over it at the end of the lecture today.
Okay, great. Thank you.
And then if anybody has any specific questions, I'm happy to go over it with you. And with that in mind, I have no clue why it decided to put one as a link and not put a picture for the other. But that's Canvas for you. I don't know why we're surprised. All right, so Scip, or the Surgical Care Improvement Project, was designed to improve surgical outcomes. Basically, it set kind of the national standard for things. If you look historically, and you'll still see that there's quite a bit of variation from one facility to the next as far as what's an accepted standard for things. And those things can include antibiotics, patient temperatures, length of hospital stay. Infections are a big part of that. So you'll see that a lot of these things kind of tie into stuff that addresses infections. So if you go back and look, each hospital-acquired infection basically increases the patient's hospital stay by at least 7 days. And this is an extremely conservative estimate, but $3,000. And the reason it's so conservative is it's very hard to tease out exactly what happened as a result of the prolonged hospital stay or the infection. And the good news is that it's hard to figure out, so it's kind of hard to, blame somebody, for lack of a better word. The downside is the government has basically taken the position now that they don't care. So from the patient side, what you see is that the complication rate goes up, so does the morbidity and mortality rate. From our side, what you'll see is that your payment goes down rather drastically the longer the patient's in the hospital. We see what we call bundled payments. So essentially, if you're having a lap chole done, the hospital gets paid $5,000 for that lap chole. And these are just random numbers. And out of that lap chole, then the payments are divided out among everybody else. So if anesthesia is billed through the hospital, then that's included in it. The PACU, any equipment used, all those sorts of things. Outside of that, individual entities will generally bill separately. So if anesthesia is a contracted provider, the surgeon's a contracted provider, they'll bill separately. But this is how much the big bundle, or how much the payment is for that lap chole. So a couple things that come to mind. One, you have to get to the money first. So you'll notice that billing is very important to process efficiently and quickly. But two, you have to make sure that you're not doing things that eat into that kind of bottom line. If I can do a lap chole with $1,000 worth of anesthesia equipment, that's great. If I do it with $2,000 worth, then the hospital is going to start wondering how the $1,000 person's getting away with it. So you really have to justify things like that. I'm not saying the $2,000 person would be wrong, but there are some things you have to take into consideration. So back in the early 2000s, CMS and the CDC put together the Scip project. At that point, it was just Scip. We added some other letters later because we like to change mnemonics around. But their overall goal was to decrease the morbidity and mortality of surgical site infections. They put together a couple initial guidelines, and since then it's really expanded, but a lot of it was focused on antibiotics at that point. So first thing was trying to figure out what antibiotics to give, because at that point, and you'll still see to some degree, antibiotic guidelines are all over the place. Dr. Bob likes Ancef, Dr. Jim likes vancomycin, Dr. Jill likes ertapenem. So there's quite a bit of variability there, and it may not be appropriate for that patient. And sometimes what we figured out is cases actually don't need any surgical prophylaxis at all. I was reading a report in the newspaper this morning, and they're anticipating in the next 20 years that 40 million people will have died from bacteria-resistant infections. One of the things that really contributes to that is inappropriate use of antibiotics. So people that are getting antibiotics for coughs, colds, fevers, things that are totally inappropriate, start developing antibiotic resistance. So what they did when they put this project together was put together a consistent set of guidelines for what antibiotics to use when. Other things they did was put together a timeline for when those patients needed to get those antibiotics. So what they were trying to do was make sure that they had the most appropriate amount of circulating antibiotics at the most appropriate time. So if you give somebody antibiotics 8 hours before surgery and it's already out of their system by the time they get to the operating room, that's not appropriate. On the other hand, if you have somebody that doesn't get their antibiotics until incision, it's probably not going to be in circulation when that bacteria load is potentially the greatest with skin contamination. Other things you have to think about from an anesthesia standpoint, if I'm doing, say, an orthopedic procedure where they're using a tourniquet, if I don't have those antibiotics in systemic circulation at an appropriate level before they put that tourniquet up, there's no antibiotic in that extremity. So little things like that you kind of have to think about. The other thing was we saw patients were getting antibiotics for a long period of time that was inappropriate. And part of that resulted in killing off the normal flora and fauna in the body. So the body wasn't able to fight infections. So the big things that came out of the initial stuff was timing of the antibiotics, selection of the appropriate antibiotics, and then how long we continued it for. Because each of those were tied into increased risk of surgical site infection. So like I said, appropriate antibiotics given in the appropriate time results in a decreased incidence of surgical site infections. And then using it too long promotes bacterial resistance. So you want to try and get those tailored appropriately for those patients. So this is what they did. They went back and looked at 34,000 Medicare patients having these types of procedures, which covers a pretty good gamut of things. And what they figured out was at that time, patients weren't getting antibiotics in the appropriate time period. For the most part, they were getting the correct antibiotics, but not all the time. And then very few of them were getting the antibiotics discontinued in an appropriate time frame. So that kind of reinforced what they planned to work on at that point. And like I said, you'll still see that patients may not get the appropriate antibiotics. But the other thing is there are patient-specific factors that come into play as well. Maybe there's a reason we're not using cefazolin for this patient. Maybe they have an allergy. Maybe they have demonstrated resistance to cefazolin, so we're using something else. So it doesn't necessarily mean you're wrong to use a different agent. You just need to have kind of a good reason for it. And this is just some of those numbers that came up about 3 years later. So you'll see that kind of the compliance for the most part increased over that time period. So we went from Scip to Scip, and Scip was basically started about 4 years later with some of that data that we just looked at. And they broadened kind of the horizons for what they were trying to treat. The other thing they did was kind of targeted the biggest offenders. So they looked for where the cost of complications was the highest, the areas with the most opportunity for improvement, and then they looked at trying to bring surgical care in line with a lot of the other different measures. And when they did this, their overall goal was to reduce surgical complications by 25% in 5 years. That doesn't seem too terribly hard to do, but you'll be surprised how things turn out sometimes. So it was started by CMS and CDC. They brought in a lot of different people. I want you guys to take a list and look at that list and see who's missing. We are. If we don't advocate for our profession and we don't step up on the national level, we lose out on things. We don't have a seat at the table. So even though it doesn't seem like it ties into things, doing little stuff like being politically active on your state level, at the hospital level, nationally, make a big difference. Because if we don't do things like that, people don't even think about bringing us into play. And the funniest part to me is that if you look at that list of people, who are the ones that are actually giving the antibiotics and making the difference for all these patients? We are, and we weren't even involved in the process. So kind of sad, kind of funny, but something for you to think about in the future. So kind of continuation of what they had before, appropriate antibiotics within 1 hour incision. And the time frame they put together for this is so no greater than 1 hour, but no less than 15 minutes. So you have about a 45-minute window in there where you can give the patient the antibiotics, and it needs to be at least 15 minutes before incision, but no more than an hour before incision. So like I said, 45 minutes to work with. If you're giving something that has to be administered over a little bit longer period of time, like vancomycin or clindamycin, they stretch that out to 2 hours. Now, if you have somebody that's on continuous antibiotics, say like Zosyn is one, a lot of times we see people being put on like 8-hour infusions. That's okay because they're maintaining that steady state. But again, it needs to be the appropriate antibiotic for that procedure. And there's a variety of different antibiotics, and there's a whole nother lecture where we talk about that. But it's just something for you to think about there. Make sure that we're giving the appropriate antibiotics. The other thing a lot of hospitals have done for two reasons, one for standardization, and two, to make sure the patients are receiving those appropriate antibiotics, is they'll have an antibiotic nomogram. And that's been agreed on by the surgical committee. It's been agreed on by anesthesia. It usually involves infectious disease as well. And that way, everybody's on the same page. The other thing that comes into play with that is not only standardized antibiotics, but standardized dosing. So Ancef is probably the most common antibiotic we give. Dosing wise, what we usually do is if a patient weighs less than 70 kilograms, we'll give them 1 gram. If they're between 70 and 100 kilograms, we'll give them 2. And if they're over 100 kilograms, we'll give them 3. And then that's repeated every 3 to 4 hours. So that kind of gives you an example of how the dosing works based off of the hospital guideline. Now, you may go someplace else where everybody gets 3 grams. You may go someplace where it's 120 kilos, you get 3 grams. So just pay attention to kind of what's going on there. Another thing they noticed when they started looking at duration of action and infection rate was that patients that had cardiac surgery really had some special needs. One of those was continuing antibiotics for a longer period of time. The other one was instead of cefazolin, which we give to most of our patients, they figured out that a lot of the cardiac surgery patients already had some degree of antibiotic resistance. So they were probably better off with something a little bit more potent, like vancomycin. So we'll see that a lot of times cardiac surgery patients go on vancomycin and it continues for 48 hours. Something else they looked at, again, primarily focused on cardiac stuff, was the use of beta blockers. And what they decided was patients that were already on beta blockers must take their beta blockers on their regular schedule. So within 24 hours of surgery start for all patients that were on some sort of beta blocker. Now, what's the problem of giving beta blockers to somebody that's going under anesthesia? What do they do to your heart rate and blood pressure?
Tank it.
They tank it, exactly. So what we figured out was patients were having bad outcomes because they were continuing their beta blockers, but because of the financial drive to meet the core measures, you still had to check that box. So it almost turned into kind of a running joke for a while. Patients would come in and get like 1 milligram of esmolol or something that wasn't even going to touch the patient, but it checked that box to make sure that they got a beta blocker within 24 hours of surgery. So over time, this has kind of fallen out of favor and been removed from the core measures. But there are certain patient populations where they still want it continued. So just be mindful of that. One of the big things you have to pay attention when you're doing your pre-op is to see if the patient's on beta blockers and then when was the last time they took it. And then something after the fact was to make sure that the beta blocker was restarted if it had been held. So just things for you to pay attention for with your patients there. Something else that seems very basic but was resulting in a lot of skin infections that then contributed to surgical site infections is what happened to the patient's hair. Most of us have hair all over our body, and a lot of times it's going to be in the middle of the surgical field. So how that hair was removed really varied from one place to another. Sometimes patients would shave at home. Sometimes patients would be shaved like with a safety razor or another razor when they got to the hospital. And what they found was not only was it causing a little bit of microtrauma and an inflammatory response of the skin, but it was also causing bacterial contamination there that was very hard to control. And then ultimately that wound up in the surgical infections. So what they decided was we weren't going to do razors, we weren't going to shave anymore. We were going to use clippers because it didn't get as close to the skin, but it still kind of grossly decontaminated that hair. So we no longer shave anybody, they're going to be clipped. Something else, just kind of from a like cleanliness perspective, you'll see there's a lot of devices out there now because the hair goes everywhere when you use a clipper. Sometimes it gets done in pre-op, but they have almost like vacuum cleaners. I don't know if anybody ever saw like a Flowbee or, you've got something to vacuum your dog's hair, but it's basically the same thing. It's a vacuum that's attached to that clipper so it doesn't go everywhere. If not, kind of the common practice is to use a piece of tape or something like that to kind of grossly decontaminate the area. The downside of using the tape is now you're putting a sticky adhesive residue someplace that you're trying to make sure is clean. Probably not a good practice. Something else that came into play and was kind of the bane of our existence for a little while in the ICU is that we reduced the amount of Foley catheters we were putting in people. And if we put them in, they had to come out very quickly. And if not, back in the day, if somebody couldn't pee or they weren't incontinent or they were intubated, we just put a Foley in. We didn't even have an order for something. It was considered a nursing procedure. But because of the increased infection rate, especially urinary tract infections, what they decided was that the catheter had to come out quickly. And if it stayed in there, there had to be an order in place to justify why it was there. And then the hospitals really paid a lot of attention to that. So what you saw come out of that was a lot of like non-invasive urinary control devices like PureWick, Texas catheters, those sorts of things. So why do we put in Foleys in the operating room? One of the biggest reasons we do it is for laparoscopic cases and then for urine management. So if you have somebody that's having a lap appy and their bladder is full, obviously that's going to be in the middle of the surgical field. So they will commonly decompress the bladder with a Foley. Now, before where we may have used a continuous indwelling Foley, a lot of times now we'll either have the patient void before we go to the operating room, or they'll just do a quick in and out cath to decompress the bladder before surgery. And if it has to stay in there, and there are plenty of reasons why, you just need to make sure you document the reasons for it. But you'll notice one of the discussions that's kind of ongoing throughout the surgical case is, does the patient need a Foley, and then how long is that Foley going to stay in place? Glycemic control is another issue that came into play, especially focused on cardiac patients, because we know that elevated and out of control sugars really impacts wound healing. So what they decided was that patients that had existing glycemic issues initially, and then later everybody else, needed to have their sugar within 180 milligrams per deciliter for the surgical procedure. So just like everything else in medicine, we kind of did the knee-jerk reaction, and instead of being reasonable about it, we went to doing insulin drips on everybody and like Q5-minute blood glucose checks and stuff like that. We've slowly backed off of that a little bit. We figured out that glycemic control was important, but it didn't really need to be as tight as we had been using it. So you may still see patients on insulin drips, but it's more of like doing a finger stick every hour, every 2 hours, every 4 hours. And the other thing was, we figured out that we may actually be causing some temporary complications by dropping that patient's blood sugar too quickly. So instead of it just being a perioperative process, we kind of extended it outside that window and looked at the big picture. So when we would take them into a pre-op clinic, we would see where their blood glucose was and try and get it under control before they went to the operating room, as opposed to waiting until kind of the morning of. And this continues throughout the perioperative period, so you'll have to monitor patients' glucose afterwards. Not that we're necessarily doing it, but it's important for us to pass it off to the PACU nurse if somebody is diabetic, and then to keep an eye on their blood sugar. It's also something for you to think about when you're writing your preoperative and postoperative orders, to make sure finger sticks are in there, and then some sort of insulin protocol if needed. Thromboembolic events were another issue. And this seems like something very simple that we would want to control. But again, you kind of got to think about, a lot of places don't have standardization. So what we started looking at was kind of breaking thromboprophylaxis down into two different measures. So you had chemical thromboprophylaxis and you have mechanical. So mechanical is what we think about with like SCD sleeves and TED hose. Though TED hose have kind of fallen out of favor because the efficacy is not as good as we thought it was. But so anybody that's having a surgical case that lasts more than about an hour needs to have SCDs placed, which isn't a big deal. It's not something we have to deal with, but it is something you have to make sure is happening. The only time it really becomes a complication for us is, say, for instance, you're using a patient's leg for a blood pressure because maybe they don't have arms, or you can't access those, or maybe that's the surgical site. So just be cautious with an SCD inflating over top of your blood pressure cuff. The other thing that started happening was we put everybody on some sort of chemical prophylaxis. So the most common ones we see are somebody coming in and getting a one-time dose of heparin, usually 5,000 units sub-Q, or a one-time dose of Lovenox. So not a huge amount of anticoagulation, but if you think about somebody that potentially has clotting issues, that may be something you want to kind of keep in mind. And there's certainly reasons not to give it, but you have to kind of do a risk-benefit analysis. If you have somebody that's bleeding to death, you probably don't want to make that little bit of clot non-functional, especially if they've got something like a head bleed or a space-containing lesion. On the other hand, if you have somebody that's bedridden, it's probably a good idea, and they should be on it all the time. So we wanted to make sure that that happened. Usually what will happen is they get a dose the morning of surgery, and then they may get a dose for several days thereafter, at least till they're kind of back to normal activity level. Temperature is a big one for us, and this was kind of added in the third iteration of the Scip protocols. And what it came down to was you had to do something to keep the patient warm in the operating room if it was a general anesthetic and it exceeded an hour. So there's some cases you don't have to do this from a core measure standpoint, but from a patient comfort standpoint, you probably still want to make sure all your patients are warm. Nobody wants to go sit back in the operating room and freeze for 59 minutes because it wasn't over that hour threshold. So the couple things that come into play here, hospitals have kind of extended it outside of the operating room. We'll see that some patients will be pre-warmed. So we'll put them on like a bear hugger or something like that in pre-op to keep them warm. And then they may use that same gown in recovery as well as in the operating room. If it's a mat case, you don't necessarily have to actively warm them with like a bear hugger, but you could also use something like blankets. You can warm the temperature of the operating room. And then something else to think about, especially if you're giving like large volumes of IV fluids, make sure you warm those up too. And where you really have to be for these patients when you get to recovery is the first temperature greater than 96.8. So usually that's the first temperature. If not, we try and warm them up pretty quickly when we get out there. Now, there are obviously some patients that we want to keep cold, and then some patients that we can't warm up as much. If somebody comes in with a core temperature of 94, no matter how hard I try, I'm probably not going to get them up to 96.8 within an hour or two. So just make sure you document that, and then document what you did to keep them warm or to make them warm. So this was an interesting study. They went through and kind of looked at compliance with temperature measures at a large number of hospitals. And what they found was that the data wasn't very good. It wasn't really evaluated well. And more importantly, it wasn't measured appropriately. So patients weren't getting their temperatures checked in recovery. And if they were doing things like axillary temperatures or maybe a forehead temperature. So if you think about somebody that's been in the operating room, say they were having an eye surgery. So their whole body has been covered except their eyes, their forehead, those sorts of things. And then I take them to recovery and they use that temporal thermometer to get a temperature. Obviously, that surface temperature is going to be colder than the rest of their body. So that's something you need to be cautious of when they're checking your temperatures, because it doesn't really matter to the patient if it's not accurate, but it matters to us from a reimbursement standpoint. So if I do something that's inappropriate, like check a temperature on a forehead that's been exposed, and then I check a temperature maybe just on their chest, and there's a 2 or 3 degree of variation, that's a big deal. So as far as accuracy, that's something to consider. Axillary temperatures are another one for the same reason. If you've got somebody's armpit that's been exposed, that's a factor. Some thermometers do not automatically calibrate to kind of account for that axillary temperature. So there's generally accepted that there's a degree of difference between an axillary temperature and a core temperature. So just keep that in mind as well. But for the most part, if possible, we use core temperatures. So esophageal, bladder probe, nasal probe, those sorts of things. This was kind of a follow-up study where they went back and looked about 5 years later, and they figured out that as patients were evaluated and kind of improved as far as what they were doing to assess temperatures and those sorts of things, that patients had a better outcome. And this is just kind of a summary of those core measures for you as you look through the whole surgical process. Any questions on Scip or core measures? So it seems like something very basic, but like I said, when it's tied into your financial compensation, it turns into kind of a big deal. All right, so we're going to transition from that to Eras, which is enhanced recovery after surgery. Teams will pop up. Our Teams is acting crazy this morning. There we go. So we're going to go back in time a little bit. Most of you probably don't remember these things when they came out, but this was kind of the original social media and handheld devices, the original Palm Pilot and the first iPod and Star Wars when they started kind of round two. So back in the day, we used to do a lot of things that made sense, but necessarily weren't the best for the patient. So this is kind of one of the big things that this Eras protocol looks at, is trying to figure out things that we can make the patients have better outcomes. So one of the big things that we ran into was how patients were treated and evaluated ahead of time and from a fluid management standpoint. And you will still see that this continues lots of places to this day, 25 years later. We have not gotten better about things. So it's really incumbent on you guys when you get out into practice to try and kind of drive change for some of these patients, because we need to do things to make sure our patients are having better outcomes, not because we've always done it that way. So this is an elderly male coming in for a colectomy. And the guideline at that time, and then still, like I said, continues to this day, is to make sure they're NPO after midnight. So NPO after midnight can mean a lot of different things to a lot of different people. So think about it this way. Pop's at home. He's coming in at 6 o'clock in the morning to have surgery, but his case isn't actually scheduled till noon or 2 or 4. So by the time he actually gets to the operating room, he's been NPO for 14, 16, 18 hours. That's a long time to be dehydrated. And then the other thing you have to think about, especially for a lot of these belly cases, is they may have done a bowel prep. So he was already in a profoundly dehydrated state because of that. And then I didn't let him have anything to eat or drink for a day. Not a good situation for the patients. We found that we had to give them large amounts of fluid because they were already they were already hypovolemic. So things you have to think about that maybe weren't the best for the patient. And the sad part was the NPO guidelines at that time weren't even being followed. These have changed a little bit over time. These are the current guidelines we use. But at the time, it was not NPO after midnight for everybody. We still went through and looked at things. We just didn't follow our own guidelines. And to this day, you'll see people still don't follow the guidelines. Whether it's because we're inappropriate, the surgeons haven't adopted kind of newer, better outcomes for their patients. But it's very important for you guys to know these guidelines and to apply them appropriately for our patients. So this is kind of a pre-op visit for these patients. We'd make sure the patient was NPO. We'd explain to them what the general anesthetic was. We'd talk a little bit about what the post-op plan was. We'd take him to the room. We'd give him some Versed and fentanyl. At this time, we really started doing the first multimodal stuff. We would give patients Celebrex or Vioxx. And what did that do for them? What was the downside of Vioxx and Celebrex?
Well, Vioxx was giving people heart attacks.
Exactly.
Celebrex.
Yeah, it was causing cardiovascular events. They were having heart attacks and strokes. They weren't hurting, but they were dead. Not a good thing, right? So we're like, it was a good idea, but we went wrong there somewhere. So you'll see that Celebrex is still used. Vioxx has been recalled from the marketplace. But this was really the initial foray into doing any sort of preoperative multimodal analgesia for people. And what we were trying to do was control that pain early on. And we'll talk about this a little bit more in a couple of minutes. But we were looking at all these different pain pathways and trying to figure out where we can make a difference. So COX inhibitors were great until they weren't. So then we got them to the operating room. Everybody got the general anesthetic back then. Very rarely did we do anything as far as regional nerve blocks. And if we did, it was usually done post-operatively for pain. It wasn't done preoperatively. It certainly wasn't done as the sole anesthetic. We would do some spinals and epidurals, but a lot of times we would do that and they would still go to sleep. So maybe not the best thing for the patient. From fluid management standpoint, we do the 4-2-1 rule, which you guys are familiar with, but we didn't really take into account other things like bowel prep. The 4-2-1 kind of accounted for our evaporative loss. PONV prophylaxis was essentially non-existent. We didn't use a whole lot of Zofran at that point. Patients would get Phenergan. We didn't really think about the dissatisfiers that were affecting our patient. And the reason I put PONV prophylaxis and pain management on here is because from a patient standpoint, those are their two biggest complaints. They don't want to hurt and they don't want to puke. So if we can do things to help our patients out and take away those big dissatisfiers, it's probably well worth it. But that wasn't really the thought at that point. And this is just kind of where we went wrong with some of our thoughts as far as like fluid replacements and empiric replacement. Even if I give something that's pH balanced like Normasol or Plasmolite, it's still a foreign substance going into the body. And it's going to create a little bit of an inflammatory response. The other thing is it's not going to stay intravascular like normal fluid does. So I may get 30 minutes of happiness and then I start causing edema. Well, what if I'm trying to make up for somebody that's had a bowel prep? So they came in and they were 2 or 3 liters down. Do I start off giving them a 3-liter bolus? Because now they're really edematous. That fluid's not going to stay intravascular. And then what if their blood pressure goes down? Do I give them more fluid? I already gave them a 3-liter bolus. I'm well over my 4-2-1 rule at this point. So a lot of times we were kind of confused in how we responded to things. Did we continue to give them fluid? And we would see people would come in for these belly surgeries and walk out of the operating room with like 8-10 liters of fluid. They'd be swollen. We couldn't get them extubated. It was just not a good situation for us. The other thing that really came into play was when patients were bleeding, we were replacing that blood with crystalloid. 3 mLs of crystalloid for every ml of blood loss just makes numbers happy for a couple minutes. In reality, I'm just making my situation worse, right? Because that little bit of hemoglobin in there is now extra diluted because I gave extra crystalloid. So our thoughts were kind of wrong on a lot of things at that point. Going on to pain management, at this point, we kind of expanded out a little bit further, and I put some things in here you can think about. But for the longest time, and continuing to this day in a lot of places, opioids are the go-to and the only pain management that's utilized. Over time, we kind of expanded out. The surgeon would do a little bit of local infiltration. It may be effective, it may not. But we kind of underestimated really the pain that patients were in from what we considered small procedures. Somebody would go in for like a lap chole or a lap appy, and we forgot how much those ports hurt when they go in. Now it's very standardized for the surgeon to either infiltrate all those port sites at the beginning of the case and at the end of the case, or for anesthesia to do a TAP or a QL block, because we didn't think about how much that hurt the patient. You'll see that a lot of the patients that have those laparoscopic cases, their biggest complaints are not the surgery itself, it's the port sites and then the referred pain from the gas. So if you can infiltrate the port sites and then do something to decompress their abdomen, get that gas out of there, something as simple as like sucking them out before you take the ports out, little things like that were pretty beneficial, but we didn't even know or think about it at that time. As we expanded out and started doing things from an anesthesia standpoint, really the first thing we started doing for cases like this was epidurals. But the problem we ran into was, one, we didn't think about it ahead of time. Two, when you start putting epidurals in older patients and patients that are kind of in non-traditional settings, it becomes difficult. So if you have somebody that puts epidurals in pregnant women all day, they're probably pretty good at it. But what if there's somebody that's just working in the main OR and they put an epidural in like once every 2 or 3 months? They're probably not quite as good at it as somebody that does it every day. So what we saw was we had a very high failure rate, and we had a hard time getting those into place. The case took longer. The surgeon didn't want to wait on anesthesia to get the epidural in there. They would just give some opioids, something like that. So you can see how quickly that became problematic. The other thing we ran into is a lot of these cases would not be effectively controlled with a lumbar epidural, and most people are not comfortable putting in thoracic epidurals. So again, increased complication rate, delay to kind of get the anesthetic and the analgesic plan into place, and patients really wore thin with people. So from there, we continued on. We started adding some other things in. Ketorolac came onto the scene, and what we figured out was that it reduced the opioid requirement. But we were doing some crazy dosing for these folks. A lot of times now we'll do like a once or twice dose of Ketorolac. We figured out that 15 milligrams is really the ceiling for it. But at the time, we were giving people like 60 milligrams of Ketorolac, and they would get it every 6 hours for like 4 or 5 days. So those patients notably would have some impact on their platelet function, and we saw that there was some bleeding. We saw that there was some kidney injury. They didn't need as much pain medication, but we had long-term complications. So a lot of the bad rap that Toradol gets came from that time period for what was probably inappropriate administration of the medication. So we've kind of gone back the other way, and now we're back to giving like a once or twice dose of Ketorolac for these patients, and they do very well. Other things that's really come into play since then is we've adopted more of a multimodal approach to IV analgesia. So a lot of patients are getting dexmedetomidine, not in the doses you were using for sedation in the ICU, but very low doses. And I'll tell you, this is still kind of an experimental area, and everybody kind of has their voodoo dose of what they're going to give or not give. From a personal standpoint, what I usually do is 20 mics during the course of a short case, 40 mics during the course of a long case. But sometimes patients will show you that that's not what they need. They need more than that. So that's something for you to think about. Some places they run dexmedetomidine infusions. It's not quite as common as it used to be because we figured out from an anesthesia standpoint, it's very labor intensive, and the patient may not really get the problem. The other issue we ran into was we were seeing lots of episodes of hypotension, and patients were really struggling with sedation and recovery. So we'd kind of gone too far past that reducing opioid uses and providing analgesia. So we've backed off of it. So you may see that 20 to 40 mics is kind of a go-to. The other thing from a logistical standpoint, it's just a little bit easier to do. It comes 4 micrograms per ml. So if I use a 5 ml syringe, I've got 20 mics. If I use a 10 ml syringe, I've got 40 mics. So from that standpoint, it may make it a little bit easier for you. Something else that's, if you look back, kind of what's old is new again, we've started using sub-dissociative dose ketamine as an analgesic. So a lot of times we'll give a bolus of ketamine on induction, and then we may do an infusion or just repeat lower doses throughout the case. The nice thing is that we're hitting other receptors outside what we were giving for opioids. So that's kind of helpful for us as well. Something else you see that you may or may not experience in your practice is kind of the balance of a lot of medications. I'm sure you guys have heard somebody talk about ketofol, a combination of ketamine and propofol, because they kind of offset each other. But you'll also see from an anesthesia and analgesia standpoint that ketodex, or the combination of dexmedetomidine and ketamine, may be beneficial. And this is just an example of kind of how I reconstitute it. A lot of times for patients that I don't want to give midazolam to, I may give them ketodex. So what I do is basically match it up where I have 1 milligram of ketamine to 1 mic of Precedex. So like if I've got 50 milligrams of ketamine and 50 in Precedex, I'll dilute that down to 5 mLs. And then I'll administer it, a cc or 2 throughout the case. And that works out pretty well. The nice thing about that is the medications offset each other. So like ketamine tends to cause tachycardia. Precedex tends to cause bradycardia, so the two balance each other out. Same thing from a blood pressure standpoint. The hypotension and hypertension of each agent are kind of offset. From a secretion standpoint, ketamine causes salivation. Precedex tends to dry people up. Ketamine has a potential for emergence delirium. Dexmedetomidine tends to calm them down. So ketodex is kind of a nice go-to as well if you're looking for something. But when you guys get to clinicals, you'll see that everybody kind of has their own little cocktails and recipes for things like this. Other things to think about as far as intraoperative management that have kind of changed over time. Teams is killing me. They keep disappearing. In the past, anybody that got a general anesthetic was getting an NG tube and would go to suction because we were very worried about aspiration. So there were a couple problems that came into play. We were definitely decompressing their stomach, but we didn't really reduce the aspiration risk. We just cleared out the stomach because they can still reflux gastric contents into the stomach. So there's still potential for aspiration even with an NG tube. The other thing you see by putting that NG tube in there, you may make it worse because you've actually put an opening through the esophageal sphincter. Something else to think about, if we're giving somebody pre-op PO meds and then we immediately turn around and put an NG tube in, we just sucked out everything we gave them. So that may not be beneficial for those patients either. We talked about appropriate antibiotics in the Scip lecture. That's still pretty consistent. Keeping them warm is still a big deal. This is another one, though, that gets kind of skipped over, PONV prophylaxis. So there's a couple things that we know contributing to making patients higher risk for PONV. Unfortunately, it's one of those things that being female affects. Randomly, it's about the only thing that being a non-smoker is a problem. Younger patients tend to get PONV more than older patients. The duration of anesthesia can affect things. Opioid use certainly does. And then people that have a history of PONV or motion sickness, again, have a risk of getting nauseated. So this is just kind of a table that shows you what causes nausea and kind of the incidence and that sort of thing. So like I said, nausea and vomiting is a huge dissatisfier for patients. So even though patients may not necessarily need to get Zofran because they don't have a demonstrated, risk, in my mind, it makes a lot of sense to go ahead and treat them prophylactically because I want to avoid the dissatisfier. For example, we don't wait on patients to wake up and have pain to give them pain medications. Why do we want to wake up and have nausea before we treat it? So just something for you to think about there. And we'll talk a little bit about kind of how you can manage it and what the evidence shows. And again, you'll see that there's a lot of anecdotal evidence that comes into play here as well. So this is kind of a consensus-based guideline, which is pretty accurate. The one thing I will say is it's a little bit older, but when you look at this, you have to really evaluate how risky a patient is for PONV. Personally, as I said, I tend to treat everyone, but from a clinical guideline standpoint, you don't necessarily have to. But I explained to you kind of my theories. Other things that come into play, if you have somebody that's increased risk of PONV, start adding on. How many antiemetics are you going to use for these patients? So something for you to think about there, and we'll talk about this a little bit more in a minute. So we get the patient to recovery. Over there, they start getting more and more fluids, and then we start giving them opioid on top of opioid on top of opioid. PCAs were huge, and what we thought was if we gave people all these opioids, it would help their pain. Now, remember what this guy was having done. He was having a colectomy done. He's extremely high risk for bowel obstruction and ileus, and then we're going to give him a ton of fluid to make his bowels edematous, and then we're going to give him opioids that are going to slow everything that passes through any part of his colon that happens to be intact. Horrible setup for the patient, but we just didn't really think about kind of the widespread impact of things at the time. So then we've gone a little bit further. 15 years later, we've got cool iPhones now, and nobody knows what a Palm Pilot is, and we started implementing kind of these Eras guidelines. So Eras stands for Enhanced Recovery After Surgery. Unfortunately for you Swifties, it has nothing to do with Taylor. This was out long before she was singing about stuff. But it's an evidence-based guideline that helps us improve our care. And one of the things I hate about anesthesia and medicine in general is protocols. But just like those skip measures, Eras protocols are kind of beneficial for a lot of reasons. And one of those is that people won't standardize stuff. You know, you work with one surgeon one day, they do one thing, you're doing the exact same case with a different surgeon the next day, and they don't. And even though we see the differences in their patients and the patient outcomes, they don't. So sometimes you kind of have to step in to do things that'll kind of overcome those long dogmas and stuff like that. The other thing is anesthesia providers are all different. And this doesn't necessarily force you to do anything, but it may provide you with kind of a reference or a guideline for what's the most appropriate way to treat your patient. So there are existing protocols. The other thing you have to think about, and we'll talk about this again in a second, is that it's across the board. This is not just an anesthesia issue or treatment. It's everybody, from the pre-op to the surgeon to the anesthesia provider. So we really all need kind of a reference document to keep us on task. There's a couple different phases I broke this down to when you start looking at things. So you have the preoperative phase, which is really like the decision for surgery to the night before. The intraoperative phase, which extends out just a little bit further than you normally think about it, because I included the morning of surgery in there, intraop and then PACU. And then after that, PACU until the time they go home or wherever they go. So these are kind of some must-have things for you to think about as far as an Eras protocol. The big one is you've got to have some sort of preoperative counseling session with the patient. Whether anesthesia does it, the surgeon does it, but somebody's got to sit down and talk about things because it's very different than all that stuff we talked about from 15 or 20 years ago. If you're asking them to drink a Gatorade on the morning of surgery and they think they're not supposed to have anything to eat or drink, that's confusing for them. So you have to explain why you want them to do that. The other nice thing is that we have to evaluate these patients before the morning of surgery and figure out their risk assessment, because that may really greatly alter their anesthesia plan. If this is somebody that needs to be done under a spinal or regional anesthetic because of comorbidities or because of improved outcomes, we need to tell them that. That way they don't show up that morning and they're expecting to have a general anesthetic and they're very surprised. I touched on this, but a lot of times we're going to have these people push the MPO guidelines a little bit. And I don't mean they stop at McDonald's on the way to the operating room, but we want to limit their fasting time. One of the big things we do with a lot of these patients is either a protein shake or a carbohydrate shake up to about 2 hours before surgery. So instead of having that NPO guideline being midnight or some vague number we picked, we're going to try and keep them fluid normal all the way through surgery. The nice thing from our standpoint is that then we don't have to give large amounts of fluid to make up for fluid that wasn't lost. We also recognize the role of reducing opioids in these patients, but we don't want them to be in pain, so we still have to have a good analgesic strategy to follow through the patient all the way through discharge. We know there are benefits to doing these things preoperatively and intraoperatively. And even if we get to PACU and they start pushing opioids, they still have improved outcomes. But what if we could continue with a great strategy all the way through? In the postoperative period, we have to think about those things that were killing these patients and causing them problems. So if I have somebody that lays in bed for days and days, they're at high risk for DVT. They're at high risk for infections. They're at high risk for not being clean and winding up with bacteria in that wound. So we're trying to push a lot of our patients to get out of bed within 8 hours of the end of surgery. We have patients that are having knees and hips, total knees and total hips done, and they're up walking in the PACU. They're doing physical therapy there. I see it every day. I'll do PANG blocks on patients that have total hip replacements, and within 30 minutes of that being done, they're in PACU doing PT, walking around. It's crazy, especially if you go back that 15 or 20 years. You think about these people laid in bed for days and days and days. It's a wonder we didn't have more bad complications at that point. The other thing is we have to talk to these people about what happens when they go home. How do we keep that incision clean? When do dressings need to be taken off? What if you have wound complications? What are things you need to come back to the hospital for? As far as mobility, what can you do? What can't you do? So some kind of specific things to think about as far as the preoperative phase. If you notice, these are a lot of those things that we talked about in that Scip assessment. We've got to have some sort of standardized process. The other thing you'll see is a lot of facilities, because of the payment aspect, have kind of documented triggers now. So if you have somebody that has a pre-op blood sugar greater than 180, they get referred to diabetic counseling or nutritional management, or they have to have a preoperative assessment done. Same thing with patients that are smoking. How can we get them to quit, but also target when we want them to quit? If you have somebody that's malnourished, it's probably not somebody you want to take to the operating room. Again, maybe refer them to counseling with a nutritional expert. Other things to come into use, like polysubstance abuse. All the patient's medications need to be reconciled, and we need to figure out what's appropriate to continue and what's not. If you have anemic patients and you can try to address that before you get them to the operating room and have to give them blood, that's better for them. Other things that we're starting to think about more and more, postoperative cognitive dysfunction is a big concern, especially in elderly patients. So we may tailor our anesthetic plan to try and address that. Other things you'll see that are kind of a big factor, the patient's body habit is. So if you have somebody that's obese and they need to have a total knee replacement done, it's common for surgeons to refuse to do that procedure until they've lost a certain amount of weight. So a lot of those things come into play for us as well, but it may not just be an anesthesia issue, it's a surgical issue. But we need to recognize kind of the role we have in this. I included this website here because I think it's really good. If you go to the mssic.org, they've got a lot of examples of tools you can use for assessing patients as well as kind of improving outcomes. Theirs is basically focused on spinal surgery and kind of general era stuff, but there's a lot of information out there. I kind of touched on this, but we've got to have a formal patient education process, and it really continues throughout the whole experience. So you may have somebody that gets educated at their preoperative visit, and then when they get to the hospital that day, you've got a flyer for them. Or maybe there's a video they have to watch before they come in. But if we can educate our patients and they kind of understand the standardized process, it really helps them be on board. And that way they don't have unrealistic expectations, but they also understand what we're doing for them so they're not surprised about how the anesthetic or surgical journey continues. So things you have to think about, you've got to have some sort of standardized content for these patients, no matter what their surgeon is, which is hard because surgeons are very set in their ways. They're very demanding, and they want things done very specifically for a lot of different reasons. It may not be the most appropriate way to have it done, even if they think it is. And sometimes getting past that means somebody has to retire or somebody has to find a new job. But as the hospitals are seeing more and more financial incentive for us to have better outcomes, you're seeing a lot of these things happening. The other thing is you want to make sure that this educational process is documented somewhere. There's a variety of facilities out there that operate in a lot of different ways. What you will see if you look at specialty hospitals like spine or joint or something like that is because they're so focused, they have a very efficient process to work through things. And a lot of this is this process kind of put into place. From a risk assessment standpoint, you also kind of have to have some standardization there. There's a lot of programs out there. One of the biggest ones we see is the ASQP program through the American College of Surgeons. But evaluate what you're doing as far as risk assessments and what you can do for it. This is an example of the College of Surgeons quality program. And this is information they're putting out there for the patients, but it's also kind of an evaluation in the screening tool. So if you have a diabetic patient and you're trying to figure out if they're at high risk, or is this somebody that needs glycemic management, this is just a quick reference for you. And it's very basic stuff. Are they diabetic? Okay. So then we probably need to look at their blood sugar. Well, what if they're a little bit older? What if they have an elevated BMI? We know that both of those put them at increased risk of metabolic syndrome. So that may be somebody we want to evaluate their blood sugar. If we have somebody that's diabetic and their A1C is out of control, they probably need a little bit more than us just checking their finger stick and giving them some diabetic medications around the time of surgery. They really need to go someplace where they're managing that disease process. And then also think about, what are we going to do with their medications? We don't want to make somebody NPO and then have them take full doses of anti-glycemic agents, because they'll arrive blood sugar of 40, and now we've got to cancel their case because their sugar's too low. So think about all those sorts of things. These are some examples of different screening tools or different risk assessments. So if you got somebody that smokes, we have to tell them to quit smoking. We have to document whether they listened. If you have somebody that's diabetes, we touched on, or diabetic, we touched on that. If you have somebody that has existing anemia, see if we can do something ahead of time. Can we get them oral iron or EPO? If it's a little bit further out, we can come back and evaluate whether that improved things, because we may need to retreat them. If you have somebody that's obese, consider a referral to bariatrics or something you can do to kind of manage their body habitus. If they are super obese or morbidly obese, you may want to put off surgery. A lot of times the surgeons know that that's associated with a bad outcome, and they don't want to have that, especially for elective or kind of specialty cases like those knees, those total joints, those backs, things like that, because those people aren't going to heal and they don't want to have that. If you have elderly patients, get a geriatrician involved, get a frailty assessment, follow up on those patients if you can. So that was all kind of preoperative stuff. Now we're going to shift to the intraoperative phase. We've got to do a better job of limiting our fasting and controlling the glycemic and volume status. So as I said, limited fasting, get that Gatorade or their carbohydrate-rich beverage in there before surgery. Do things that will reduce opioids. And it may be, when I say reduce opioids, I don't mean they don't get any opioids at all. It may be something that gets them to a steady state a little bit faster. So maybe instead of giving them IV fentanyl, I give them a longer lasting PO medication that covers 12 hours, as opposed to giving them multiple doses of fentanyl or morphine or hydromorphone, something like that. Think about things that you can do to reduce the risk of infection. So maybe we're not putting a Foley in unless the case goes over 3 or 4 hours, or we have a documented need. Ask the patient to void before you take them back to the operating room. If they just peed, you're probably not real worried about their bladder being full. Think about other things that may be able to reduce blood loss. Minimally invasive surgeries, administering things that help with hemostasis like TXA, calcium, stuff like that. And then these are just some goals down here for you. Maintain normal volemia for these patients. So if they haven't been NPO, that may help. Do they really need to have a bowel prep done? What can I do to keep them warm? Is this somebody I need to put blankets on? Is this somebody I need to have a bear hugger? How can I control their blood sugar? What can I do to reduce the risk of nausea? If I put a Foley in, does it need to stay in? Stuff like that. This is just kind of a series of goals that are pretty helpful for you. I put the reference down because it's really a great lecture. If you go to that MSSIC website, there was a presentation done by an anesthesiologist talking about Eras, and he had some great information in here. So I would look at this slide. The next one kind of covers some similar things. He presented a lot of the evidence here as far as why they did what they did. And stuff that didn't seem like it makes sense, or some things that we worry about. Like if I'm giving somebody a Gatorade 2 hours before surgery, do I have to worry about them vomiting? Is there an increased aspiration risk? I just gave this person something huge to drink. So that's something that's actually been disproven. These are some options when you start looking at pain management, and this is for neurosurgery. A lot of times neurosurgery patients are very difficult to control their pain because they've had long-standing issues. So what can we do? First thing is when we have that educational meeting, that preoperative screening, set realistic goals. If they've been in pain their whole life, they're not going to magically wake up and it's all better after somebody spends 4 or 6 hours cutting on their back. So tell them we want their pain to be manageable, but pain is not going to be a zero. So what can we do to control that? One of the big things that's come into favor is the use of gabapentin preoperatively. You may see that a lot of these patients are already on preoperative gabapentin. So make sure that they're getting doses and you may need to increase it. A concern from a pain standpoint is how much gabapentin am I giving and is it going to cause sedation postoperatively? But for these patients, especially like I said, neuro patients, they're probably already on gabapentin, so it may not be a big deal for them. Other things to think about that have pretty clear benefit, use of NSAIDs. Opioids are still in play. They are still our go-to treatment for pain, especially outside the operating room, but they're not everything. So think about other approaches. Acetaminophen can also be used throughout this process, but this is really what we want them to use controlling their pain when they get home. We want to taper down the doses of opioids and try and rely on more over-the-counter type stuff like acetaminophen or some topical stuff. Intraoperatively, is this somebody I can give a block? Is this somebody the surgeon can infiltrate the field? Is this somebody I can use kind of adjuncts like betamethasone or dexamethasone, muscle relaxers? And then one thing you have to keep in mind, even if you do everything right, they may still have pain. We've got to have a rescue plan for this patient. Can I give them IV ketamine? Can I give them IV opioids? Because we don't want our patients to suffer just because we're trying to avoid one medication. So make sure you've got a rescue plan for these patients. This is just an example of some of the Eras protocols. This one's from a Cleveland clinic. And this talks about a lot of the stuff that we're going to do for these patients. When we do our acute pain lecture, we're going to talk about some of this stuff again in a little bit more detail. But these are just examples for you. You'll see some places follow all these things. Some places follow none of these things. So make sure you're familiar with the culture at your facility, because as I've said multiple times, if you're the one person doing something, you're probably going to be wrong. Post-operatively, what do we do with them? We talked about getting them out of bed early on. We want to try and get them back on a good nutritional status. So keeping patients NPO for quite a while after surgery may not be beneficial either. Kind of a common practice for these patients to kill two birds with one stone is to get them up out of bed in a chair, and that's where they're eating all their meals. So this may not be somebody that can do long walks, but maybe I can just get them out of bed to a chair and they can eat there. We do this a lot with our cardiac surgery patients. Other things to think about when you're discharging these patients, incision care, recommendations from mobility. And when you're sending these people out, even if it's not any of these things that we've talked about, think about red flags. Maybe this is somebody I did a nerve block on, and I'm telling them that this is what I want them to worry about in the next 12 to 24 hours. So maybe it's that patient I did the nerve block on. At some point, that nerve block's going to wear off. They need to know that. I don't want them, avoiding pain medications, and then they wake up in excruciating pain when that block's worn off. What if this is somebody that I've blocked a motor nerve? They need to understand that they're not going to be able to move their arm, leg, what have you. What about that incision? Your incision becomes red, it starts to weep, or they start to develop signs of compartment syndrome, nerve weakness. Things like that are stuff we really need to make sure we tell these patients when we're discharging them so they're aware of it. And then what are we doing as far as follow-up? When are they coming back in? Is this something they need to call about, or is this something that can wait till their 1 week, 2 week follow-up, whatever you have going? So hopping back to fluid management, what we really transitioned to instead of the shotgun approach with like the 4-2-1 rule was goal-directed therapy. So we're using a lot of monitors, especially like non-invasive stuff. ClearSight is one I use in a lot of my practices if the patient doesn't need an arterial line to help evaluate their volume status. We realized that crystalloids may not be the go-to we always thought they were, so we're using colloids in a little bit bigger role than we had in the past. And that does come with some risk, but it's something you need to think about. We've also transitioned away from giving everybody normal saline because we know it's not a great agent to use for these patients. These are just some examples of kind of non-invasive and invasive monitors you can use. Like I said, ClearSight is great. It's just a non-invasive blood pressure cuff, but it provides you a continuous arterial tracing. So instead of having to put the art line in, have that time hack and the risk of infection, vascular compromise, I can just put a little blood pressure cuff on their finger and it provides me with a fairly accurate arterial measurement. This year at Symposium, Edwards is going to come and they're going to talk to you guys about some of these non-invasive monitors and how you can apply them to your practice. Some of us have a wealth of experience with it. Some of us have no experience. But this is really where the future lies for these patients. So it's something I think you need to become familiar with. Something else to think about. Do we still need a bowel prep for all these patients? What we figured out was if patients didn't have a bowel prep, that they got bowel function back earlier, there was less risk of ileus. They did better with their diet. They were in the hospital longer or shorter. The surgeons were really worried that if we cut out that bowel prep, that there was an increased risk of infection or leaks, and there wasn't. So that was kind of a win-win for both of us. And then the other thing was we took away 2 or 3 liters from that fluid deficit. So we weren't throwing extra salt water in there to make up for things. So we talked about this earlier on as far as like what we can do to reduce the pre-op fasting time. The big thing is that carbohydrate loading, getting them a Gatorade, which I think is probably the most common thing you see up to 2 hours before surgery. I touched on this before, but there's not an increased risk of aspiration. Our patients aren't thirsty. They're not hungry. They're not anxious. We're not seeing an increased rate of insulin resistance. We don't wind up with patients losing their body mass like they were from all that fasting. They do better, they're out of the hospital faster, and they have a faster recovery. So one of the things that we really focused on when we were doing opioids, especially PCAs in the past, was how to keep our patients comfortable. And what we thought was by giving them a PCA, we let them have control over their pain medications, which is true. We were giving them an option. But the problem we ran into was they had to be in pain and had to be at certain levels of pain before they would use it. And then outside of that, if they didn't have the PCA, we were doing all these peaks and valleys as far as controlling the patient's pain management. So what we really want to do is something that lasts a little bit longer. Neuraxial opioids are a big one. Regional anesthetics are a big one. Avoiding PRN opioids is another one. But if you're putting somebody on a PCA, instead of just having demand doses, make sure they've got a baseline rate. Because like I said, we're trying to get to that steady state and stay there. Morphine is kind of our go-to as far as or kind of our baseline evaluation. So morphine equivalents are how we measure opioid use. But what we figured out is patients that are just getting those IV opioids don't maintain steady state very long. And they also have an increased risk of nausea and vomiting. So if I can do something to avoid those opioids, I tend to have a much lower rate of nausea and vomiting. And this is not only opioids as far as from an IV standpoint or PCA standpoint, but epidural and neuraxial opioids do increase the risk of nausea and vomiting. So if I can avoid them, I tend to do a little bit better off. From an OB standpoint, a lot of times we'll put fentanyl or Duramorph in our spinals or epidurals. And what we figured out is that the patient may benefit from a regional anesthetic for long-term pain management versus having those opioids added in there. So it's somewhat common practice for us to do tap blocks on patients instead of putting Duramorph in our spinals now. This just kind of highlights what I was talking about, but I think the most important thing for you to think about is this bottom sentence. Patients really need to receive an around-the-clock regimen of COX inhibitors, NSAIDs, or Tylenol. We have this habit of not doing consistent pain management and just letting the patient drive it. So we'll let them be in pain, then we'll have them ask for opioids. If we give patients 24 hours of these medications, NSAIDs, Tylenol, skeletal muscle relaxants, COX inhibitors, all these sorts of things really provide them with a lot better pain coverage than making them hurt and then ask for an opioid. So this is really where we stand as far as pain management now with a lot of these different medications. We're hitting a lot of different receptors in a lot of different places, and our patients are having better outcomes now. Multiple agents offer a lot more benefits than a whole lot of one agent. So we're going to talk a little bit about kind of multimodal pain management for these patients. We've talked about these different medications kind of individually, but there's a lot of things that you have to look at as far as reducing opioid requirements. So if I have somebody that I give an NSAID or a COX-2 inhibitor and I'm able to reduce their opioid requirements by 20 to 30%, that's pretty significant. What if I add Tylenol on there and now I'm up to 40 or 60%? It's a little bit harder to calculate things like ketamine and dexmedetomidine as far as how much they reduce the opioid requirements, but I've already potentially reduced my opioid requirements by 60% with just 2 classes of medication. I may be able to get away from using opioids entirely when I add in all these other adjuncts. So you'll see that some places they do a lot of opioid-free analgesia, especially as part of these Eras protocols. Other things for you to consider, regional anesthesia. For a long time, it was primarily focused on extremities, but we can use this throughout the thorax and abdomen as well. Things to consider: use of erector spinae blocks, transverse abdominis plane blocks, placement of epidurals. Very beneficial for these patients. Something else you have to think about is, how do you time this? So if I have somebody that's going in for a surgical procedure, I'm able to do these blocks before they have that surgical pain, I may be able to reduce any sort of other medications I give them. So having a block is obviously beneficial, but if I can administer that block before that surgical pain is there, they tend to do a little bit better. The other thing is, you see that from a anesthesia standpoint, they're very stable throughout the case. There's nothing that makes me happier than looking at somebody that's got train tracks for vital signs throughout their time in the operating room because they had a good block. Same thing down in the abdomen. We can also add in QL blocks. Very beneficial. One thing for you to think about as far as doing a TAP versus a QL is that the QL tends to be a little bit more reliable for sensory blockade than a TAP block, but it's also technically more difficult. And the reason for that is our patient's body habitus tends to play a huge role for those patients. So you may be able to do a QL, but a TAP is better than nothing. So just think about that for those patients. We can do TAP blocks anywhere. You'll see that after you start recognizing this anatomy, that you can do it in the chest. You can do it when I say chest, I mean like subxiphoid. You can do this down in like an ilioinguinal, is basically a very low TAP block. So the potential to hit this nerve is pretty beneficial throughout the abdomen. Just some images for you guys to think about there. One thing you'll see is that not all facilities do regional anesthesia for abdominal or chest cases. They may still be stuck on just doing it for extremities. Hopefully we'll see that continuing to change, but you may be the change. You have somebody that's high risk for nausea and vomiting, somebody you don't want to give opioids, and you just prompting that suggestion of, hey, what do you think about doing a TAP block for this patient, may be enough to get things changed in that facility. So other things for you to think about when this kind of comes into play is, what are all the components you have to think about? Things that are generally pretty straightforward: the preoperative counseling, the discharge planning, the bowel prep, VTE, pre-warming, antibiotic prophylaxis. Those are pretty clear, but things that people struggle with a little bit more from a mental standpoint are, is it okay to cut this fasting time down to 2 hours? Is it really okay to give these people, this Gatorade? We know it works, but trying to get people on board with that sometimes is difficult. So I've said it multiple times, but we should allow everyone to have clear fluids up until 2 hours before induction of anesthesia. And then what about all these medications we were talking about? How does that fit into things? You'll see that we push that envelope even a little bit further, and a lot of times we'll give them those medications up to 30 minutes per procedure with a sip of water. Now, trying to swallow pills with a sip of water is not really a good time, but it's probably not the best time for them to have a big glass of water before I induce anesthesia. The other thing is solids up to 6 hours beforehand. Now, I'm not talking about Burger King with onion rings and a milkshake, but we can have solids in there, little basic things, crackers, chips, light meals, not fried stuff, fatty stuff, big protein loads, but little things. Other things for us to think about, we touched about this earlier on. What can we do for people? I think this is really a little bit better approach to addressing PONV. The other thing you have to think about is there's so many different agents out there we can use to treat PONV. It may be stuff that we're doing all the time and we don't even consider it. If I give somebody a regional anesthetic instead of putting them under general anesthesia, that's a treatment for PONV because they don't have that general anesthetic trigger. Or what if I'm giving somebody Decadron, or I'm giving them Zofran and Decadron? All those things can be beneficial. What if I'm doing a TIVA with propofol? Again, propofol is a great antiemetic. So think about all those different things there for these patients. Other things that are, as we kind of drive along. So active warming is okay, multimodal is okay, avoiding NG tubes is okay. But what about this goal-directed fluid therapy? How do I do that? Am I worried about underperfusing my patients? How am I going to monitor that? Avoiding long-acting opioids. How do I take care of this? What is our dependence on opioids, not necessarily theirs? Lots of people use opioids for their whole pain management strategy. So they're really relying on it. It's not the patient. How do I find the balance between taking care of my patient, but also doing what I think I need to do? So lots of things to think about there. I think this big one down on the bottom is that anesthesia is not cookbook is something you have to take into account. If I'm trying to avoid opioids for somebody because I'm worried about damaging their opioid receptors or their brain, but they've been on, hydromorphone 5 milligrams umpteen times a day, that ship has sailed. They're not opioid naive. But it's just something for you to think about. Don't always do the same thing because that's what you're comfortable. You really need to tailor your anesthetic plan to those patients. So what are the barriers that we run into when we think about implementing an ERA strategy? This was kind of a cool article, is that they went through and talked to all the people. The surgeon's going to blame anesthesia is going to blame surgeons. But I think this bottom one is really the biggest part. People are very skeptical of change. Like I said multiple times, when you do something different, it's wrong until proven otherwise. So I think that's a big one for you to think about. You have to prove this works, and it's not going to be a matter of just showing them studies. They're going to have to see that the patients do better before they really buy into a lot of these concepts. So what are the big outcomes we're seeing here? Reduced use of morphine equivalents, improved pain scores, which is crazy that we're not giving them as much morphine, but they're still feeling better, and they're getting out of the hospital faster. So if they get out of the hospital faster, there's less risk of nosocomial infections. But the big thing and what you have to do to drive this and sell it to the hospitals is they don't have that hospital cost. They're not taking up that bed. So my anesthetic may cost a little bit more because instead of using 10 milligrams of morphine, I'm using ketamine, Precedex, all those things. That little bit of buy-in may be enough to get them out of the hospital faster. I can give a lot of medications to make up for one day being out of the hospital. So think about that when you're treating these patients. These are some cool examples for you guys and things I think I would go through and look at. Both of these are from the AANA, and they cover the kind of ERAS guidelines for anesthesia. So what questions do you guys have about ERAS stuff?